Assalamu alaikum. Yes, Bismillahirrahmanirrahim. As you know, accident is an accident, and it happens accidentally. But unfortunately, it has happened today. And our delegates, our speakers are stuck in the traffic jam. So we have decided that since we have to stick to our timelines, we have altered our program. So we will start with the first session. I would request Dr. Abdul Qayyum Shah, ex, and take his chair as a chairperson. I would request Dr. Farooq Soh, consultant surgery, District Hospital, Handwara, to take his chair as the chairperson. I would request Dr. Mahmood Rashid, Associate Professor of Surgery, GMC Baramulla, to take his chair as and the chairpersons, please start the proceedings.
Dr. V. consultant, Lord Dasuri, is present chest trauma and then of coverage.
Respected HOD, Department of General Surgery, Professor Dr. Shira, Organizing Secretary, Dr. Kara, and dear other colleagues and faculty members. Assalamu alaikum. I am going to present a topic about the chest trauma and its management. It is a very important topic. As you know, that the trauma is the leading cause of death, hospitalization, short and long-term disability for all ages. 25% of all trauma deaths are due to chest injuries. Out of them, 20 to 33% deaths are preventable. And 85% of patients with life-threatening injuries can be managed by simple interventions. So this is a bullet injury of the chest, as you are frequently seeing in Kashmir. As we should know about the anatomy of chest, we have two lungs, one heart, a diaphragm, and a chest wall. And in between the chest wall and the lung cavity, there is a space known as pleural space. This is the major vascular trunk of our human body that is mainly in the chest cavity. The main causes of the chest trauma are blunt trauma, penetrating trauma, or compression injury. The main injuries of the chest are pneumothorax, flail chest, cardiac tamponade, traumatic aortic rupture, traumatic asphyxia, diaphragmatic rupture. The main diagnostic tool for diagnosing the chest trauma is the chest X-ray, in which we can see emphysema, pneumothorax, hemothorax, or widening of mediastinum. The other tools are ECG, USG chest, CT chest, and echocardiography. These are some slides I have incorporated in this presentation just to make it interesting, although it has nothing to do with the presentation. Life is like a sea. If there are no ups and downs in your life, that means the person is dead. Simple pneumothorax or closed pneumothorax, we will say, is an opening in a lung tissue that leaks here into the chest cavity. Blunt trauma is the main cause. It may be spontaneous. It is usually self-correcting. The main symptoms are chest pain, breathlessness, cacophony, and decreased breath sounds. The treatment is as this airway breathing circulation and C-spine control, advanced trauma life support, followed by basic life support, in which we will see monitor for the development of tension pneumothorax, and we have to investigate the cause of simple pneumothorax. The second one is life is the most difficult exam. Many people fail because they try to copy others. not realizing that everyone has a different question paper. Open pneumothorax. This is an opening in the chest cavity that allows air to enter the pleural cavity. It causes the lungs to collapse due to increased pressure in the pleural cavity. It can be life-threatening and can deteriorate rapidly. This is the open pneumothorax. The person inhales the air during inhalation and exhales during exhalation. But a time will reach when there will be development of tension pneumothorax and the lungs will not expand anymore. The symptoms or signs are dyspnea, sudden short pain, emphysema, decreased lung sound, and sucking chest wound. This quotation is important. If we will apply this quotation in medical science will flourish. Ego is the only requirement to destroy any relationship. So be the bigger person, skip the E and let it go. Emphysema, it is a air collects in the subcutaneous vein from the pressure of air in the pleural cavity. It feels like bubble red. It can be seen from neck to groin area. This is a sucking chest wound. The main treatment of this is tube thoracostomy. This is the occlusive dressing we apply in a open pneumothorax, 3-side covered, 1 side is open. And we can also apply this Asherman chest C. Try to not become a man of success, but rather to become a man of life. About tension pneumothorax is very serious condition. The air release in the pleural space with no way for the air to escape. Results in the collapse of lung on the affected side, pressure on mid-aspinal lung and great vessels. This is each time we inhale, the lung collapses further. There is no place for the lung air to escape. This leads to the trachea is pushed to the good side, heart is being compressed. These are symptoms and signs. Use of accessory muscles, hypotension, tracheal deviation. The main treatment of this condition is, if there is an open pneumothorax, do occlusive dressing, as I have already mentioned. But we have to do for tension pneumothorax, we have to do needle decompression of the affected side, then tube thoracostomy followed by slow decompression. This is the needle decompression. This is mainly done in the second or third intercostal space in mid-clavicular line. We insert 14-gauge needle into the chest cavity, about 3 inch, and then we remove the gush of air comes out. This is the photograph showing the needle decompression, second intercostal space in the mid-clavicular line. This is the flat valve we use in this condition. We can also use a finger glove or a latex glove and or Asherman chest C. Know about the pneumothorax. It occurs when pleural space is filled with blood. Each lung can accommodate about 1.5 liters of blood. This is the pneumothorax. It may put pressure on the heart. The main sources of blood are, it may be from the bronchial arteries or intercostal arteries. These are the main sources of blood for pneumothorax. Their symptoms or signs are shock, bloody sputum, tachycardia, diminished breath sounds on the side, flayed neck veins. The treatment is, as already mentioned, advanced trauma life support followed by tube thoracostomy. If drain is 1.5 liters or 400 ml per hour for 4 hours, then we have to go for thoracotomy. And we have to also look for the development of pneumothorax. Patient may need intubation if needed. This is the flail chest. This is a breaking of 2 or more ribs in 2 or more places. This is a chest X-ray showing multiple rib fracture on 2 places. It presents with shortness of breath, swelling, cryptus. Flail chest is a true emergency. The treatment includes high flow oxygen, applying of this bulky dressing, triangular bandages or D5 bandages we apply on the chest till the patient is shifted to the nearest center.
Hello?
And we have to monitor for the development of tension pneumothorax, and we have to do decompression of the chest. Pericardial tamponade is the collection of blood in the pericardial space that causes compression of the heart, so the diastolic frequency is decreased. cardiac output gets decreased and heart rate gets increased. Presence with distended neck veins increases heart rate, respiratory rate increases, there is a narrowing of pulse pressure. And hypertension, ultimately, if not intervened, it leads to death. The main treatment is pericardiocentesis, where to rapidly transport to the patient to the emergency OT. In pericardiocentesis, we do, under all aseptic conditions, we put a needle at the specified junction, and it should be towards the left clavicle, and we should draw the whatever blood is there or fluid is there, we should draw it out. And as I have already mentioned, it's a dire emergency. We should treat it as immediately as possible. Traumatic aortic rupture. The heart more or less just hangs from the aortic arch, much like a big pendulum. It occurs in motor vehicle accidents or from the sea or from the tree. The chance of survival are very less. But if there is a small tear, then the patient has a chance of survival. He can be survived. There is he may present with tearing sensation in the chest, dropping blood pressure, pulse rate increases, loss of consciousness, and the main treatment is immediately shift the patient to the theater and under sternotomy, do sternotomy and cardiopulmonary bypass during death. Education is not the learning of facts, but the training of mind. There's a traumatic asphyxia. It results from sudden compression injury to the chest cavity. It causes major rupture of vessels and organs of chest cavity and ultimately death. It may present with these symptoms. The main treatment of this is shift the patient to the ICU and intubate it and know their cause. Diaphragmatic rupture mainly occurs on the left side because on the right side is being protected by liver. It is associated with the multiple organ injury. This is a chest X-ray showing diaphragmatic rupture on the left side with internal contamination to the chest cavity. The signs and symptoms are abdominal pain, shortness of breath, increased breath sounds, bowel sounds are decreased. Treatment is mainly treatment thoracotomy and evacuate with proline. And we have to also monitor for the development of tension pneumothorax. The basic crux of this is chest tube insertion. How we put the chest tube? Chest tube is a thin plastic tube that doctor inserts in the pleural space between the chest wall and lungs. It is used for many purposes. The main uses are empyema, pneumothorax, pleural effusion, pneumothorax, pleurodiscs. The types of chest tubes are chest tube comes in French sizes. They range from 6 to 40 French. It has 3 parts: tip, body, and tail. Large bore is 20 French or more. Small one is less than 20 French. It can be put under general anesthesia outside, but here we put it under local anesthesia. We have to elevate the head of the patient, raise arm on affected side, identify insertion site, mainly third or fourth intercostal space, fourth or fifth intercostal space, posterior pectoralis major. Clean the skin with iodine. This is the main position for chest tube insertion. This is the main site. We have to insert the lignocaine and then insert the chest tube. Usually we make 2 to 3 centimeter incision. Through Kelly we widen the incision, and through glove we put the glove finger in and put the chest tube in. Then attach it to the container and suture it and then do X-ray. This is the chest tube placement after giving local anesthesia. This is how we will be suturing, and the chest tube is connected to the container. When we have to remove the tube, there should be no this fluid, this blood should come out, and the procedure is usually uncomfortable, but should be painless. Know what about surgery amid COVID-19? These are some slides. That with 19 we have done many surgeries, and that has been published in the leading now newspaper just for the awareness of the people, not for the publicity. The surgery department COVID-19 and Rural Medical College Baramulla. The laparoscopic kidney surgery is being done as a beginning in a new rural institute. laparoscopic hernia surgery, ADFD in North Kashmir, laparoscopic ovarian cyst removal by the general surgeons, and gastric stomach cancer surgery, first time at a medical college, Baramulla. Injuries are so common, the crux is that we have to do early intervention, identify it and do early intervention, don't take it easy. Alhamdulillah. So this picture is very important in this world of 5G, where the patient knows everything and doesn't differentiate between medical negligence and complication. A doctor has to be more vigilant and he has to protect himself from the patient. Thank you very much.
Excellent presentation on chest trauma. Thank you very much, Dr. So you just general surgeon. Excellent presentation on chest trauma. I think from 2000 to 2016, I, along with my colleagues, we have must have put almost more than 50 chapters. We are doing just off and on, during night, in the afternoons, during day, till we got a serious surgery, dual. When we got so scared when we talk about complications. We were very politely, but since he came, he made us clear of just complications. The process slowed down. I don't know what is the status today, putting still scared. But I think one just to put in time is almost, as I compared with 100 routine surgeries. You can save a person in time after putting just and then refer to the higher center. I think we have saved one life. In Holy Quran we have was that to save one life, it is equivalent to save 4 human lives.
Secondly, I want to tell you that to all my friends in the audience, Dr. Mushtaq is a doctor with difference. All of us are working, but most of the times our work means within the confines of our office or our hospital. Mushtaq is the one, he remains connected with the public. He always writes, he highlights difficulties of their fraternity and tries to increase awareness in the public and educate the public. And that is a rare quality, and he has a very nice writing pen. God bless you. We are happy with you.
Thank you, Dr. Mushtaq. Very nice presentation of chest trauma. I just want to ask you, we are great peripheries, on and off put in chest tubes, but is chest tube enough? Where can we do emergency room, thoracotomy, and what should be the chest tube drainage where the patient will be safe? There has to be a criteria where you think that chest tube is not enough. You have to go beyond that. Could you kindly elaborate on that? You got my question?
Actually, putting a chest tube in an emergency procedure is a life-saving procedure. But there are indications why we can use converted to thoracotomy. Dr. Mushtaq has said it that when there is initial radiation, you have a patient on RTA or some other blood test, you put the casualty, you put the chest tube. If the stat, you have put the chest tube and the drainage has come more than 1.5 liters, 1500 ml. That's a one indication. We can go for a thoracotomy along unstable, modernity unstable. Second indication is that if you are monitoring a patient, then per hour it is more than 350 ml or 300 ml per hour drainage over a period of 5 hours, 5-6 hours. That also becomes an indication for a thoracotomy. Third indication is when you are suspecting that there is a pulmonary artery injury. Pulmonary artery injury is where you have put a chest tube, gush of blood will come out. Not even 1.5 liter, even 3 liters, 4 liters will come out. So these are the indications of absolute indications of thoracotomy. Otherwise, you can just manage by putting a chest tube, monitor the patient. Then when you remove the chest tube, removal of the chest tube depends upon the two things. One is the drainage to the chest tube, and second is the air leak. What happens is that most of the times when we put a chest tube for a hemothorax or a pneumothorax, we monitor the drainage. If the drainage day by day decreases, initially it was 300 ml, second 24 hours was 100 ml. What we prefer is if it is less than 50 ml, we remove the chest tube after monitoring for 24 hours. Along with that, there should be no ear leak, because ear leak is a very important component. If you have ears in the lung during the putting the chest tube, parenchyma, there may be a chance of bronchopulmonary fistula. That time you don't have to remove the chest tube, because you remove the chest tube, ear will get accumulated inside the tubular cavity, again because of collapse of the lung. So the two things you have to be sure: there should be no ear leak, there should be no drainage of the chest tube, or less than 50 ml.
That was exactly my point. We basically can only put in a chest tube. And then whether we have to shift the patient or not depends upon what will be the initial drainage, number one. Number two, what will be the hourly drainage. Because you cannot keep on admitting the patient, keeping in a painful hospital where he is draining more than 250 ml per hour. So you need to set it to a chest tube is a life-saving procedure, but it is not enough. If there are further complications, major injury, major option, then you have to shift the patient.
You have to definitely shift the patient. It's a life, but you need to put it. Because
you need to put that.
You cannot shift it.
That is what my point is. You need to put it and then decide.
Because he will die if you shift him without chest tube.
Then decide what further.
Better is to put a chest tube than to fear further complications.
And in peripheral hospitals, you have constraint of blood also. So that also has to be kept in mind. You decide to observe the patient or to send it to a hospital.
There is one thing which we have to remember about chest tube. Once you put a chest tube and maintain an underwater seal, chest tube does give only benefits. If it does not fail, it doesn't harm you. So we should be liberal in putting.
Yes.
Whenever they do, please do.
And the theatre should be very, this paramedical staff should be very expert. They should be knowing that what must, the water, how much should be the water level in the chest bag. Because sometimes what happens, you put the tube, they don't know, in putting the normal saline patient dies, they have one pneumothorax.
Obviously, that doctor has to do all this.
And that has happened many times. In shifting the patient from periphery, the accompanying person was not knowing. And they have put the chest tube, but the air was going in.
I said, good drain, baby.
Dr. Shah, what is the recommended site for insertion of chest tube in hemothorax and in pneumothorax?
Pneumothorax, as I mentioned, it is of different types. In tension pneumothorax, we have to do first decompression. Because what happens if in tension pneumothorax, we will put the chest tube, the air will come in a rush, that will lead to pulmonary edema and patient will have
In pneumothorax is the site also 15 intercostal space?
For needle decompression, as I mentioned, it is second and third intercostal space in the midclavicular. We have to put the 14 gauge needle so the air will come out. For hemothorax, we put in the 4th, 5th or 5th, 6th midclavicular space, 5th intercostal space, posterior to pectoralis major.
Dr. Swan, actually, the chest tube is put in the triangle of safety. It is put in the triangle of safety. The anteriorly is the lateral border of left pectoralis major muscle. Posteriorly is the anterior border of principal dorsal, and the base is formed by the 5th intercostal space. So you can put anywhere in this triangle of safety.
Only landmark, because it's really difficult to differentiate that kind of borders and muscles and other things. Simple landmark is the nipple. Identify the nipple, put the bit of an anterior axillary or mid-axillary line and put it in that. But most of that applies only in males.
But that applies to males, not in females.
Females only in males, there is a pendulous breast which is going down. But the thing is that
get it to admission, it will guide you to admission. The simple landmark is why nipple, because it is in the 4th or 5th intercostal space. It will not go in the 6th or in the above, because there are chances you go into the down and rupture the liver. Also, the identify the nipple, go into the mid or anterior line. That's the only landmark.
One more thing to say, remember this is when you are applying in children, possibly these guidelines are not rigid. In children, you put in a 4th space, whether it is pneumothorax, whether it is going to drain. So because the chest as such is labile in children and a lot of that fixity which is adult, that does not happen. Dr. Mushtaq, needle proportion has to be done in all cases of transfusion. We cannot put just two vessels.
No, we cannot, because we have seen one is the doctor that Altaf Bukhari, his mother, I think grandmother, she died because of the tension pneumothorax. And casualty chest tube was put directly and she developed pulmonary event. She arrested on the day we had patient. So we have, yeah.
I had to talk about that we are suspecting a pulmonary condition. That is the reason I got the chest tube. But whenever anesthesia assistant is found some postgraduate put the chest tube in the casualty skins and she didn't do it as she expected. I have written a proper note that patient might be a thoracotomy.
But at least you put in a medicine authorized, you can put the chest tubes on the appendix and other than
Sometimes we receive patients with flail chest, where a segment of chest is just whole of it is going. At this level, what are we supposed to do? The patient.
We have to do good analgesia. Because in flail chest, there are two things. The reverse broken, the reverse guard inserted into the chest cavity. So there is a pneumothoracx. If there is a cryptation, emphysema, so we have to put the chest tube immediately. And the good analgesia should put the patient at center. We have to monitor oxygenation, saturation. If patient any time drops saturation, oxygen, then we have to go for intubation and mechanical ventilation.
Thank you very much, Dr. Fox. Next speaker.
Ladies and gentlemen, I have the pleasure of announcing our arrival of
Master's mother, I think.
Ladies and gentlemen, I have the privilege of announcing the arrival of the chairman, Human Technical Chapter of the Assistant Surgeon of India, Professor Fazal Qadi. Unfortunately, as you know, we met a bad there is a traffic jam, there is an accident has taken place on the highway, and most of our delegates are stuck up on their own road, including our chief guest and principal. I just heard that some encounter has started to sound here. God's keep us, pray to God, keep safe us and our guests. So we'll continue the proceedings as long as we continue, we will keep on joining.
Now, Dr. Shakib Nabi, GMC Baramulla present, GMC of Robotics, GMC Baramulla from reception to advanced surgery. Dr. Shakib.
Respected chairpersons, respected Professor Fazal Qadi, respected head of the department surgery, seniors and dear colleagues. I'm Dr. Shakib Nabi, I'm assistant professor in department surgery, and I will present before the respected gathering the journey of the Department of Surgery, GMC Baramulla, from the inception to date. North Kashmir basically is
It's a very big area which actually comprises of 3 districts. District Baramulla, District Kupwara and Bandipura, which till 2018 were served by their respective district hospitals. And there was no zonal referral center. The 3 districts as per the 2011 census have a collective population of 2.2 million. Why was a tertiary care required? There were multiple reasons for that. One of the biggest reasons for tertiary care being available in North Kashmir was that a lot of referrals had to be made, which were burdening already overworked tertiary care hospitals. We are in the process of compiling the data of referrals since 2019. It's in progress. And we wanted a center which would serve as a referral center for the surrounding districts and the towns. Now I give a brief overview of the Department of Surgery. More often than not, when you embark upon a new journey, you have no idea as to where one would reach and what that path would be. As said by Sir Walter Elias, all our dreams can come true if we have the courage to pursue them. Our department is headed by a dynamic, experienced and a visionary surgeon of repute, Professor Allah Hussain Shera, had a vision and discrete objectives when he took over the charge of department in 2019. Supported equally by competent and dynamic associate professors, Dr. Hakeem Wakar, Dr. Mahmood Rashid, and all our consultants and residents, we embarked on this beautiful journey 2 years back. The journey is going to be long and arduous, but as they say, well begun is half done. When we started this department from a district hospital to a medical college, so we had to have a vision. So our head of the department, he carved up a vision for the department on which we are working our best since 2018. So our utmost importance was on to provide state-of-the-art patient care with competence and compassion, of skill, and conduct research and scientific programs to contribute to future surgical practice. No surgery department in a medical college can be complete without performing their academic responsibilities. And in that regard, the Department of Surgery has started providing training to undergraduate students from the current academic year. Contribution is also extended to the teaching curriculum of various paramedical and nursing courses run by the institution. Regarding emergency and trauma, this is one area where there's a lot of focus on upgradation of the emergency and the trauma services. Because this is one area where there were a lot of referrals taking place. So starting at 24-hour emergency service, including trauma, has been the main focus of our department since the time of inception. A dedicated emergency team is available around the clock in the emergency. The upgradation of infrastructure vis-a-vis emergency trauma services is in progress. There are logistical challenges, but I can assure this August gathering that we're on the right track and there will be tangible improvements with every passing day. Regarding the surgical part, our department has been in the forefront of diversifying the nature of procedures that were being done or inherited from the erstwhile district hospital Baramulla. In this regard, we have started operating stomach, colon and gynecological malignancies with a robust inter-department liaison to ensure evidence-based treatment and patient safety being our foremost priority. Pediatric surgery procedures are being performed in children as young as 6 months to 1 year, which weren't previously being done. Since January 2019, our department has performed 937 laparoscopic cholecystectomies, 360 aneurysm procedures, 86 open hernia repairs, and 6 cases of stapled hemorrhoidopexy, to mention a few. Besides, we have made significant progress towards minimal access procedures in general surgery and urology. I would definitely like to mention the name of Dr. Hakim over here because he's been a guiding help in the progress of minimum access in this hospital. And these procedures have now started to become a part of the routine. So this is a slide of a laparoscopic hydrated cystectomy done in our hospital. In the last 2 years, we have also operated upon 33 groin hernias through minimal access tap or tap, 24 ventral hernias, where we either did an abdominal wall reconstruction or an ICON, 43 laparoscopic appendectomies, 17 diagnostic laparoscopies, 8 hydrated cysts, and 4 laparoscopic pyelothotomies. The numbers may not say much, but I think this has to be taken in consideration that we lost a lot of months to August 5th, and then COVID took 6 months of the routine surgeries. So this is a slide of showing the dissection in a depth laparoscopic hernia repair. Now coming to the scientific responsibility part of the department. The faculty has been actively participating in conferences, both physical, virtual, and sharing their experiences at the national and international levels. The faculty has been going as examiners to national institutions as well as in Jammu and Kashmir, institutions of the repute of Aligarh Muslim universities, and they have been part of the apical selection committees elsewhere in the country. Our department presented a scientific paper in CELSCON 2019, which was a national level conference and won the first prize for it. In the past 2 years, we have the distinction of having published 5 original research papers in indexed journals of repute, and 2 are again in progress. Sir, I want to share with the August gathering here that we have 2 studies currently going on in the department. One is about non-operative treatment of appendicitis, and another is on field block and ventral hernia surgeries, which we are doing in collaboration with the Department of Anesthesiology. And we are maintaining the highest degree of research methodology in both these studies. Besides, we also participated in a multi-centric study on global attitudes in the management of acute appendicitis during COVID-19 pandemic. It was a study which was conducted by the Association of Italian Surgeons in Europe, which was published in BJS, and our institute also participated in this multi-centric trial. So, about the academic expansion, we're in the process of starting a dry skills lab where we can impart structured training to future and practicing surgeons in peripheral hospitals for the safe practices in minimal access surgery. In this regard, we would also like JAKASI to extend help, any support for this, because strengthening the training part in peripheries has become very important now. If we have to cut down on the complications in peripheral hospitals where people do not have access to regular training, I think it becomes very imperative upon this institute that we start a dry skills lab. We are also awaiting permission from National Board of Examinations for starting the postgraduate residency program in the discipline of general surgery from the next academic calendar. Future vision for the department. We want to create surgical subspecializations in the department for excellence in patient healthcare. In this regard, sir, I would let the August gathering know that we have already started doing neurosurgical procedures. We have started doing CVTS procedures. With urology is in full bloom now. But there are logistical challenges which may take some time to overcome, but our persistence, inshallah, will help us to achieve the goal. We want to adopt newer teaching methodologies like computer-generated modules and skill labs, as I already talked about that. And one of the dreams of our head of the department in our previous meetings has been to start a dedicated trauma center in North Kashmir, which will be affiliated to GMC Baramulla. It seems a difficult dream, but we dare to dream about this, and inshallah we will do our best, whatever can be done in that regard. This task is uphill, but with the dedicated and vibrant leadership of our worthy principal, Professor Ruby Rishi, and the vision of our head, Professor Altaf Hussain Shia, and the dedication of our respected faculty and residents, we will strive hard to achieve our mission and become a center of excellence. And in the end, I just want to say a quote by Theodore Roosevelt, who said, "Do whatever you can with all you have, wherever you are." Thank you so much.
We shall start the shower of the debate. Thank you. This is the command of Allah for the whole humanity. Respected Chief Guest, Professor A.T. Ahmed, Honorable Principal GMC Baramulla, Professor Ruby Rishi, other dignitaries, ladies and gentlemen, Assalamu alaikum and a very good afternoon to all of you. I thank you all for traveling near and far to attend this day-long conference. I feel privileged to welcome you all on behalf of Department of General Surgery, GMC Baramulla, for today's academic activity themed on surgery amidst COVID-19. Ladies and gentlemen, our chief guest for today is Professor A.G. Ahmed. He is an eminent cardiovascular thoracic surgeon and Director State Kashmir Institute of Medical Sciences. Sir, may I request you to please take a seat on the dais. I humbly request Principal GMC Baramulla, Professor Ruby Rishi, to join our chief guest on the dais. I am glad to invite Chairman, JNK Chapter, Association Surgeons of India, Professor Fazl Q. Parekh on the dais. Next, we look forward for the presence of Professor Altaf Hussain Shia, Chairman, Organizing Committee on the dais. I request Organizing Secretary Dr. Hakeem Bakar Ahmed and Dr. Afaf Yusuf Sherwani to please share the dais with the dignitaries. Now, our medical students from GMC Baramulla will present bouquets to the dignitaries. Ms. Tahrim Nisa will present bouquet to our worthy chief guest, Professor A.T. Ahmed. Ms. Shireen Fatima will present bouquet to the patron of today's event, Professor Ruby Rishi. Sahil Singh will present bouquet to the Chairman, GMC Chapter, Association Surgeons of India, Professor Fazl Q. Parekh. Ms. Tahrim Nisa will again present bouquet to Professor Altaf Hussain Shia, Chairman, Organizing Committee. Ms. Shireen Fatima will present bouquet to Dr. Hakeem Bakar. Mr. Sahil Singh will present bouquet to Dr. Afaf Sherwani. Thank you all for adding grace to the stage. Let's start our day with the verse of Holy Quran. I invite Mr. Shabir Ahmed from Department of General Surgery to come on the stage for Tilawat Quran part.
فيغفر لمن يشاء ويعذب من يشاء والله على كل شيء قدير. آمن الرسول بما أنزل إليه من ربه والمؤمنون كل آمن بالله وملائكته بين أحد من رسله وقالوا سمعنا وأطعنا غفرانك ربنا وإليك المصير. لا يكلف الله نفسا إلا وسعها لها ما كسبت وعليها ما اكتسبت. ربنا لا تؤاخذنا إن نسينا أو أخطأنا. ربنا ولا تحمل علينا إسرا كما حملته على الذين من قبلنا. ربنا ولا تحملنا ما لا طاقة لنا به واعف عنا واغفر لنا وارحمنا أنت مولانا فانصرنا على القوم الكافرين. صدق الله العظيم.
Jazakallah, Brother Shadid, for refreshing our schools. May I request Professor Ataf Sanchira, Head Department of General Surgery and Chairman Organizing Committee, to present the welcome address.
Chief guest, Professor A.J. Director, Chief International Sciences and ex-officer Secretary Government of Jammu and Kashmir, the Principal Government Medical College Baramulla, Professor Cyber, Chairman, Jammu and Kashmir Chapter of the Association of Surgeons of India, Professor Fazl Kyopari, Organizing Secretaries of the today's event, Professor Hakim Akar Ahmed and Dr. Afar Shirwani Saab, our visiting professors, Professor Salim Saab, Professor Moti Saab, Professor Ajaz Saab, Professor Chalku Saab, in particular, one of the illustrious sons of that is Baramulla and ex-head of department of urology schemes, Professor Baldev Singh Nazir Saab, heads of departments, professors, Dr. Sabra Khani Saab, our treasurer of the JAKASI, and all faculty members of the GMC Baramulla, all delegates, ladies and gentlemen. It's a matter of great pleasure for me to welcome all of you to this continuing surgical education program being conducted by the Department of Surgery, Government Medical College Baramulla, under the leadership and patronage of our dynamic principal, Professor Abhinish. It's really a moment of great pride and privilege for me to welcome our honorable chief guest, Professor A.J. Amgar Saab, at this academic feast. Sir, we are fully aware of your hectic and busy schedule at Solar, your additional responsibilities at Signals Medical College, and lot of engagements which you have at your office, but still you accepted our invitation and chose to be with us this morning to create this occasion. We really feel honored and delighted by your guest. On behalf of my principal, on behalf of the faculty of this college, on behalf of the Department of Surgery, on behalf of the organizing committee, and on behalf of all of us here, I express a deep sense of gratitude and thankfulness to you
for spending your time and joining us this morning after traveling such a long distance. This may be your first visit to the Government Medical College Baramulla, but let me inform you, sir, you are not alien to us. Most of the staff members, particularly in the Department of Surgery, of this have been your students. In addition to that, we have some of your MCH students whom you have guided. They are working in this department. They include Dr. Masin, Dr. Mushtaq, Dr. Feroz, and they are very strong pillars of the Department of Surgery, and they have performed a very good job here. So it will not be wrong for me to say that if you are not here physically, but your teachings, your expertise, and your technical hands are already with us all the time, performing day in and day out. I've been always insisting your students to maintain a good liaison with you, so that words of wisdom keep on flowing from top to this institution, which will help us in shaping this institution. Sir, the decision to invite you as the chief guest was not an incidental happening. It was a well thought over, conscious decision of the organizing committee headed by Professor Robi Rishi. Considering your stature, considering your accomplishments, considering your image, considering your persona, we sincerely feel that you are the best person to honor us on this day. As an outstanding teacher, an illustrious surgeon, an eminent health administrator, and a person with extraordinary leadership qualities made you the best choice for this purpose. And I am sure that you are the right person to encourage, to inspire, to enthuse our students and young doctors by your pearls of wisdom. Professor Robi Rishi, our principal, has been involved in shaping this program from the very beginning. She has taken keen interest in the preparations of this program and has been guiding us at every stage by her extraordinary leadership qualities. Thank you, ma'am, for your help, encouragement and guidance. I wish to express a hearty welcome to the Chairman, Jammu and Kashmir Chapter of the Association of Surgeons of India, Professor Fazil Farid. All through these preparations, he has been guiding us, helping us, and encouraging us by his advice from time to time. Sir, you are welcome. I also have immense pleasure of extending hearty welcome to the stalwarts of surgery present here. I am particularly grateful to Professor Nisar Ahmad Chaudhary, the founder president of the Jammu and Kashmir chapter of the Association of Surgeons of India. We are very indebted and we feel graceful by your presence here, sir. I also want to welcome Professor Baldev Singh Wazir, illustrious son of District Baramulla, who has been the first secretary of the JAKASI and has played a role in propagating the knowledge of surgery from districts to villages to include up to Ladakh. I welcome Professor Mufti Mahmood, Professor Iqbal Salim, Professor Ijaz Rathar, all other colleagues who are made it to Baramulla today in spite of all the difficulties you had on the way. Friends, all of you know that this college was inaugurated on 1st August 2019 with a promise that our college building will be delivered to us by the end of 2019. But unfortunately, we faced a bumpy road after the inauguration. Immediately after inauguration, there was that abrogation 370 article event which almost took one season when nothing was done. Subsequently, we tried to start afresh last year in early 2020, but unfortunately COVID pandemic came in our way. So all these, both the events brought our progress to a standstill.
there could be no constructions, no procurements, no recruitments, and virtually we lost 2 precious years. Otherwise, we would have been better placed by now. You must have heard the story of that old man who did not shave all his hair throughout the winter. And then when spring came, he went to shave his head and beard. When he came back, there was a thunderstorm and there was a hailstorm. And when he came back, he came crying home because of the pain. Then his wife asked, what happened to you? He said, Sarmadwati Ole Parge. That is what happened to us. So our situation was something like that. We are hopeful that with the efforts of our principal, of our administration, our district administration, and the JD government putting together efforts to deliver the college to us by June this year. Friends, I'm sorry that we had to conduct this program in this small, which is basically a lecture hall. I know your stats, I know your standards, I know your stature, and we all realize that you deserved something better. But we had some constraints. This is the only place we have available in our college at the moment, and inside, outside in town also, we don't have any better place available. So I will apologize for any deficiencies you will come across, you will see, find out, and because of a constraint, I will ask you to forgive us for there in labs anyway. However, as chairman of the organizing committee, I promise you that when you will come here next time, we will have an auditorium of our own, a high-tech auditorium with all modern gadgets, with all communication facilities. You will not have any grievance. Inshallah, let's hope that that day comes as soon as possible. Please, on the dais, and friends in front of me, I once again welcome you again. I am very thankful to you that you made it to this function today to grace us and to encourage us. My feelings I will express in just 3 words to all of you: gratitude, gratitude, and gratitude. And this is my best attitude. Thank you very much. I just want to thank you, and we have eminent speakers here. His pearls of wisdom will be coming, and we will be listening to them. Thank you.
Thank you, sir. I call upon Dr. Hakeem Bakar, Associate Professor, Department of General Surgery, for presenting an overview of General Surgery Department, GMC Baramulla.
Thank you, Dr. Altaf. Thank you, Dr. Yunus. Bismillahirrahmanirrahim. Respected Chief Guest, Professor A.G. Anger, Director Skills and ex-officio Secretary to the Government. Honorable Principal, Professor Ruby Rishi. Professor Fazil Kyopare, Professor of Colorectal Surgery, Scripts and Chairperson, JAKASI. Professor Altaf Hussain Shera, HOD Surgery, GMC Baramulla and Chairman and Conference Chairman. Dr. Afaq Sherwani, Consultant Surgery and Organizing Secretary. And my dear teachers, colleagues, residents, friends, and other staff, and of GMC Baramulla. Assalamu alaikum. At the outset, apologies for bringing you all to the classroom, the stage of life which you left long time back. But as you know that we started with a meager infrastructure, we carved out of a medical college out of a district hospital. So a lot of compromises had to be made. But this didn't deter us. We tried to use it optimally. Inshallah, next time we invite you, we will be able to house you in our state-of-art auditorium, which will be coming up by that time, and the one which will commensurate with your status and dignity. And accident is an accident, and it happens accidentally, but unfortunately it happened today. So I again apologize for the inconvenience which was caused to you while coming to this place. It is a matter of great pride to me to see my mentors on the dais and in the audience. I have the privilege I have had the privilege to work with Professor Anger during my senior residency way back in '93. It was a great experience which had a lasting impact on my professional attitude. That was a time when we in SKIMS 2 had a very little resource, human resource especially, to work with. Just 4 senior residents in the whole of surgery department, including the specialties. And the consultants too were very sparse. We kept the flag of CBTS flying in that difficult time also. I remember we would operate together for 10 to 12 hours. So long because sometimes we would be without protamine and we would have to wait for the heparin effect to wean out to close the patient. So I think we remember that time. And then after that we had a protocol in the department that we used ourselves to manage the patient in the ICU for 20 hours. And the great part of it is that Dr. Engel would come to the ICU, he would give me time off so that I could go to the hostel, eat, stretch out a little, and come back and be with the patient. Thank you, sir. With that kind of training and inculcation, it would have been against our deportment and demeanor not to move ahead on the academic front. Here in GMC, we were eager to do an academic event even before this so that we would all converge for an academic feast. But for the events of August 55, and then the pandemic kept it beyond our means to do so. We continued at it, and we finally were able to accomplish it today. Thanks Almighty. In the overwhelm of COVID, we all struggled, and since this was going to be one of the first non-virtual CSEPs, the theme just zeroed in on to surgery amidst COVID-19. COVID-19 has been a mind and nerve boggle. We didn't know the disease, but we had to face it, and with a lot of presumptions and hypothecations. It was a difficult situation as we had to treat our patients, and we had to rescue ourselves too. Sometimes we thought open surgery was safer than laparoscopic surgery. Sometimes we said vice versa. Respirators and masks were debated endlessly. OT protocols were revisited, debated, and restructured. Hopefully, we have succeeded in controlling and predicting the impact of this virus on our work. Now to talk about our department, which is just as old as the medical college, less than 2 years. We started with a small faculty, but had no residents. In due course of time, a few faculty members got on with us, and our residency program also took off. We are having 3 surgical units right now, with Professor Ataf Sanshera heading Unit 1, I'm looking after Unit 2, and Dr. Mahmood is heading Unit 3. Each unit has an assistant professor and a consultant, and I have the privilege of having 2 ADs. In addition to providing 24-hour emergency services, we are doing 6 OPDs and 6 routine OPDs a week, in addition to the emergency surgeries. The referrals have gone down and are steadily going down. Only those cases are referred which need higher center management. We are providing services like general surgery, including minimal access, trauma, and cancer surgery. And we are doing a good amount of work in pediatric surgery, urology, CBTS, and neurosurgery. While doing all this, we are doing our bit in the teaching also. Our department is taking both theory and clinical classes and the foundation course classes also. With a small faculty, doing this is a bit too much, but no one is judging. No one flips about it just because we have an amazing team. Thank you.
Thank you, sir. I request Professor Fazul Tupari, Professor Department of Colorectal Surgery Schemes and Chairman JMP Chapter, Association of Surgeons of India, to deliver the chairman's address.
Our lovely chief guest, the Director, Shared Experience of Medical Sciences, and ex-official Secretary Government of JNK, Professor A.G. Anger, Principal and Dean of GMC Baramulla, Professor Ruby Rishi, then my worthy teacher and organizing chairman of the event, Professor Altaf Hussain Shea sir, professors from all the medical colleges. A very good afternoon to all of you. JAKASI, as many of you must not be knowing, we all started getting together, getting the momentum and starting to invite, because we needed to have a prerequisite number of members to get a state chapter status. We worked hard on that, and that's how it became a reality. But still, I would say it is just 10th or 11th year. It is still in its infancy, in its childhood. It has yet to see its youthful days, the blossomy days of the youth, which are still to come. But I will honestly and humbly submit that because of the very dynamic surgeons who are in the front row, second row, third row, they have always worked in tandem with us. They have always supported us in each and every event. That's how it became a uniform language for all the state in whole of J&K, including Ladakh. Even that time, Ladakh still continues to be a part of us so far as state chapter is concerned. And I want to clarify that it has not been degraded to union territory status too. ASI continues to hold us with the chapter status. Even as a chairman, I represented there that since our state has been reduced to union territory, does it degrade us also to the union territory status? But they said a big no, and we continue to hold Ladakh with us at the time being. So that's a good thing. I feel good that our some of the postgraduates in the last 3-4 years have reached up to the regional level, but could not make it to national level. But there is always a way to go ahead, and inshallah we'll be doing it in the coming years. Then one more purpose was to increase the comradeship, the belonging, the sense of belonging to each other is very important. And I am sure that in the coming years we are going to realize it more, because most of us already have no families of 2 kids, and most of them will be working outside, and you will that time crave to have a comradeship with all your old friends, with all your old surgeons, and it will be a very, very important thing for the coming years to realize, to understand. So that is what comradeship is very, very important in the coming years. So these have been the basic objectives, and to achieve this we have done some things, like we have been going from all the corners in this decade. We have been going to Karna, we have been going to Gurez, we are going to Kashtwa, Doda, Badarwa, Samba, I would say Danyam Kadima, very, very remote areas, Gazigund, Udhampur, and we have conducted very wonderful workshops there, academic programs there, teaching programs there, and this has not only helped to propagate the knowledge, this has also helped us to interact with the local population there. Like I asked one of my seniors one day, what did you learn from this camp once we were in Gurez? He said, sir, the only one thing I learned is that I will never say no to admission of anybody coming from Gurez. Because I can understand now how difficult it is to reach tertiary care in Srinagar, or how many difficulties they must be facing. So this is the ground level assessment, what you perceive once you do these things. And trust me, it's not only then going there and you get a time off. You get an off routine from the routine schedule. It refreshes your souls. It really refreshes your souls once you are doing it out of your sweet will, once you are doing it out of your soulful duty, you really love to do it. It gives you the peace of mind. Then you connect with the people, you connect with your difficulties, with their difficulties. You connect with the surgeon who has spent aloof there for years together, for decades together. We have spent out of time. He feels that some of my brothers have come and they are belonging to me. They have rejuvenated the academic candle in me, and they have rejuvenated the feelings for the minimal access. Like one of the examples, I remember we went to Kargil, and those surgeons very fondly requested me, sir, you are the chairman, why don't you get us a laparoscope? Luckily, the chief guest that day was the MLC of that region, and I requested him firmly, and trust me, within 6 months they got a laparoscope. This is the amount of trust people have in us. As an association we can do more, it's not as an individual we can do things. So these are the main achievements. Our postgraduates, our youngest, now they are presenting at national level, they are presenting their bagging prizes. Our worthy faculty, they got an acknowledgement because of this state chapter at the national level. Trust me, the J&K was considered as a hilly region, as a remote area in the Association of Surgeons of India. Nobody would be acknowledged here, but because of the hard efforts of our great surgeons like Professor Anger, Professor Shera, Professor Nisar Chaudhary, Professor Munir Khan, Professor Baldev Singh Wazir, Professor Iqbal Salim, Professor Ajaz Rathar, Professor Mushtaq Chalku, Dr. Nazir Wani, Dr. Mumtaz, Professor Mumtaz from Anantnag Medical College, then Professor Nasib Chandigra, Professor Tariq Azad, Professor Chungu, Dr. Harbans, and Professor Ajaz Malik, my dear colleague, and so many from so many areas, Dr. Hakeem, Wakar, Dr. Afar, they have been presenting at national levels, going to these conferences, and this has produced an impact. Now, no more J&K chapter is considered to be an orthodox chapter and an elite chapter, a chapter which are behind in academics, which don't know things. They are very much impressed with the presentation we make. They are very much impressed with the quality of work we are doing in manual access surgery, quality of work we are doing in all fields of surgery. Trust me, it has created a momentum. It has given us respect there. So, my request would be to join this chapter more and more, because from the numbers of 120 when we started, we are already 357, but we need to be one of the most vibrant. This is some important thing what I want to stress on the youngsters, that it's not something which I have to personally, it is my property. No, I don't own it. It's your property, your belonging, it's an association. So this is one of the important things. And one of the important things which made us, this chapter made us realize that we could dream. We could dream of presenting a paper in the national center. We could dream of being respected in the national center. And what Dr. Abdul Kalam Azad has very rightly said, dream is not something what you see in the sleep. Dream is something what you see in day, what you conceive, what you perceive, what you honestly, what you are passionate about, and then you realize it. But at the same time, you have to be realistic that if it is in this dream, you think of only I and me, it's going to be a very selfish dream. You are not going to land anywhere. It should be the dream of we and us. That's Then, I would say, I would like to express big thanks to organizers like Professor Altaf Shera, Professor Hakeem Akar Ahmad, Professor Dr. Sherwani, and all his dynamic team, all of the vibrant surgeons whom I saw presenting paper. I saw Dr. Shakib presenting a paper of the work done at GMC Baramulla. And I was so much thrilled to find that even at this initial stage, they have been a part of COVID study at an international level. They have already a paper in BJS. They have already presented 5 international papers. That's a very good, that's a real great good. I would say that there have been many people in this gathering who have been doing it, like Professor Mukti is there. We are there, but honestly, it's not a big thing for us because we are already old institutes. But the thing being done here is really, really remarkable and appreciated. I would request Professor Ruti Reshi, the worthy dean and principal, that she should, at the time of inception, try to set up an ethical committee. That would be a very, very important thing to go ahead in the way of and have a very legal ethical committee which can make your papers high impact and they can be accepted everywhere. So I am thankful to see that such vibrant and dynamic team of my dear students, my dear colleagues, friends who are at Baramulla District Hospital and Baramulla GMC. They are going to make it a big thing in the coming years. I am very, very sure about this. Then I am really want to express my gratitude to Professor Saeed Masood. I think he has left. Dr. Saeed Masood, your medical superintendent, who has been always very, very active. It's my second time to come here, very warm, very welcoming, and he is really, what always impresses me about him, the way he's always immaculately dressed and his mannerism. I at times wonder why he's here. He should have been somewhere in Hollywood. So, honestly speaking, he's a very, very impressive personality, and I'm always moved by his mannerism. And the most unpredictable thing we carry with us is life. As all of you know, you should remember, This is the biggest amanat with us, is the life. Like all of you are witness to last year's turmoil. Last year was a very heavy year on our chapter. Like we lost our stalwarts. I remember Professor Dr. Abdurrashid Sherwani, who was the son of the soil from this Baramulla district, with red cheeks, white silvery beard. He was always shining in the front rows of our academic meetings. But unluckily, COVID did not spare him. We lost a stalwart in him. We lost a very good listener in him, a very good senior consultant in him. Then Professor Nazir Evani, my guide, my mentor, dean faculty, and head of department of surgery, who had been operating on hundreds of CS stomachs in his career and would give them a life of hope, had to melt down himself with the carcinoma stomach. We could not save him. Then, very recently, even Professor Nazir Wani presented one time the very prestigious Professor Mahmood Khan oration for our chapter. Then very recently, our Dr. Khurshid Iqbal, who has been the first postgraduate of Sher Kashmir Institute of Medical Science in the Department of Surgery. He, in fact, in our virtual annual conference in the month of December 2020, presented K.C. Sharma oratory lecture. And everybody, I remember Professor Mushtaq Chalku paying some brilliant tributes to his oratory and other things, how nicely he had worked all over the globe to spread the knowledge of trauma, to spread the knowledge of the BLS, ALS throughout the globe, and even in the valley, how hard he had worked at Dobivan to train people. Again, we never knew that he would be no more with us in the month of Feb. He just succumbed to the complications of COVID. Then some of our non-colleagues, like I would say Professor Rashid from pathology, we again lost him. Even though he didn't belong to the surgical fraternity, we lost him. So it has been a very, I would say, disheartening year for all of us. But I would say, in their honor, I would say simply one thing, that badlane tere baad bhi mawzoo-e guftagoo, badlane tere baad bhi mawzoo-e guftagoo, tu ja chuka hai phir bhi meri mahnoom rahe. Let Almighty give peace to their souls, and let us take a lesson from these deaths. Today we are here, we don't know next time who will be here. So let us try to do something. Let us not waste these opportunities. This is a great opportunity God has gifted us, that you are a surgeon, you are a doctor, you are a pathologist. And it should not be that we should be wasting our time in just talking against each other, in just blackening our hearts with the feelings of hasad, with the feelings of just negativity. No, with just feelings of going to press against our own systems. Unluckily, just starting with khaate usi mein khed karte hain. We waste most of our time in those activities. You don't take these things to this next world. You don't take these things to the next world. Kindly, our life should be a meaningful life. Our life should be a contributory life. It's an opportunity, don't waste it. Opportunity God has given us. There are very little things in this universe, a lot of negative, but we should be at our level trying to contribute, because God has given us the opportunity to be a doctor. So, we should not be going back. We should not be going back to the next world with this feeling कि मेरी जिंदगी मेरी हसरतों के सिवा कुछ भी नहीं, मेरी जिंदगी मेरी हसरतों के सिवा कुछ भी नहीं, ये किया नहीं, वो हुआ नहीं, ये मिला नहीं, वो रहा नहीं. Never go back. Please try to contribute something. Please try to do something better for your community. And I would request all of you to stand up for 1 minute in the honor of the bereaved soul. Thank you. Thank you. I will conclude by saying long live JK chapter, long live ASI. Thank you.
Thank you, sir. Sir, it was the highest diploma of unification for all surgeons already. I can assure you, as a student, as your student, that we are going to follow your footsteps in future. Now, it's my honor to invite Professor Ruby Rishi, Principal GMC Baramulla, and Patron of today's conference. Ma'am, please, the grace of occasion in your vice words.
Assalamu alaikum wa rahmatullahi wa barakatuh. Bismillahirrahmanirrahim. Rabbul Mashriqaini wa Rabbul Maghribaini. Fabi ayyi alai rabbikuma tukazziban. O Lord of the East and Lord of the West, then what of the bounties of your will tonight? Esteemed Honorable Chief Guest, Professor A.G. Anger, Director Schemes, ex officio Secretary Government, Secretary to Government. Chairman JAKASI, Professor Fazl Kuyum Faresa. Chairman of this event, Professor Altaf Sarshera Sahab. Vice Chairman, Dr. Saeed Masood Sahab. Then we have our dignitaries of the dais. HOD, Department of Surgery, Skills, Dr. Nisar Chaudhary, Dr. Salim Sahab, Professor Salim. Then we have HOD Surgery, HOD Surgery, GMC Nagar, Dr. Mufti Mahmood Sahab, HOD Surgery, Skills, Medical College, Professor Ejaz Sahab. We have our ex-HOD Urology, Skills, Professor Balgay Sahab. I see Dr. Chalku Sahab and all other dignitaries there in the rows, the administrative staff, all doctors, their colleagues, their friends, and we have the joint organizing secretary, Dr. Mahmood Rashid, and all the organizing committee members for this event. I welcome you all. It's really a matter of great pleasure to have you here, sir, despite your lot of, you can say, busy schedule. It gives me immense pleasure that to be a part of the inaugural session for this event, which is being organized amidst COVID-19, and the theme of the event being surgery amidst COVID-19. You see, it has been over last more than 1.5 years that the world turned upside down with this pandemic of COVID-19. Everything changed. Life came to a standstill. Places or cities which were hyper-resolute like New York, Italy, Spain, whole of Europe, Asia, and a number of the countries were prepared. So, a lot of challenges came up. Challenges on the healthcare, challenges on the psychosocial, challenges, very complex challenges. People were literally locked down in their homes. Children were locked down, they could not go to schools. Roads were all deserted, life got paralyzed. But here I remember a very simple saying, as you sow, so shall you reap. This Mother Earth has been throttled to that extent that nature sometimes takes a course to resettle and rebuild. History has evidenced such pandemics, such epidemics, such disasters, natural calamities, which are unfortunately becoming more and more frequent. So let's see what happened to the healthcare. Healthcare got its own challenges to diagnose the disease, to treat the disease, to overcome the difficulties, because a war was there was a war or a battle which was uninformed, which we were not knowing that it would be there. None of us were prepared. So the brunt on the healthcare workers, our doctors, our paramedics, the nursing staff, all cadres of healthcare workers and frontline workers bravely fought against this situation. They lost their lives They did not care about their families. They did not attend their homes for, you can say, months together. Really, we should appreciate their, you can say, contribution to fight against this pandemic. So, if we see what was the scenario of other things beyond fighting against this COVID-19, the medical care, the medical emergencies, the surgical emergencies, the maternal and the child care services, obstetric services, they were going on. Life seemed like being paralyzed. But these facilities, they continued with lots of effort. And I'm happy to see here that the topic is that how surgeries took place amidst COVID-19. I congratulate the organizers of this event once again for coming up with such a brilliant topic, and I hope that this event will be very useful and it will have fruitful meaning. Its outcome should be good. All the participants, all the, you can say, those who are attending should try to see what we learn from it. Outcome should be excellent. We should be active and we should also we can interact with each other to make it very healthy and meaningful. So once again, with these words, I thank my honorable chief guest. Here, I just briefly also take 2 minutes to see that I have taken as Principal Medical College just 10-15 days, and what we are here witnessing is just the birth of a medical college. Now this medical college, inshallah, will be groomed and it will be brought to the status of excellence, not only in the northern Kashmir, but in the whole of the Union Territory, and inshallah, it should be one of the colleges or institutes of excellence in the country. Each passing day will show its results. And as Dr. Fazil Akbare had already said about committees, yes, the first week I started formulating committees because I have given around 32 years in a medical college, and I know that what is the importance of these committees. So especially the ethical committee, the medical education committee was already in existence. We have to have a hospital development and a college development committee. We have to have other important committees where all the parameters of academics, social, cultural, everything is taken into care. At the same time, imparting best of the academics, revising their roster, checking their schedules. We have to also see that our doctors, they come to duties regularly, they do their work regularly, their attendance will be checked. It's not only the question of marking the attendance, which I have observed. They have to stay in their hospital and in the duty during working hours. This is a very important message I want to give to my doctors and all other staff members. It's not just a question of marking attendance. Kindly be in your duty hours within your designated places, number one. At the same time, we have to work as a team, we have to have positive attitude, we have to support each other, and with the support of our higher authorities, I'm sure this college will come to a status of excellence. Thank you. I wish you all the best.
Sorry, on behalf of JAKASI, I forgot one thing. That was to congratulate Professor Virishi on achieving I have known her in the government medical college days. We were junior to her by 2 years, but she was a very brilliant student, very bright, but she would steal the limelight on the sports day by bagging too many medals. They were very, very athletic, and she has proved her academic caliber in the department, and administrative caliber in the department of pathology, where she really improved the postgraduate. She increased the number of postgraduates. She has got it administratively at a higher level. I am very, very sure that GMC will see the brightest days in the coming years.
Thank you, Professor Fazil. Thank you, ma'am. May I request our worthy principal to felicitate our chief guest. Can I have a moment, please? I request our worthy chief guest to felicitate our honored request. Then I request our chief guest to felicitate Professor Kusari. Professor Asaf Sanchera. Dr. Hakeem Akar Ahmed. Dr. Afar Sherwani. Thank you, sir, for doing honors. Now, I request Principal GMC Baramulla, Professor Ruby Reshi, to felicitate Professor Nisar A. Chaudhary, Honorary President, J&K Chapter, Association of Surgeons of India. Professor Baldev Singh Wazir, former head urologist and Professor and Mr. Sanawar from Baramulla. Dr. Dr. Salim Khadim, Honorary Treasurer, J&K Chapter, Association of Surgeons of India. Dr. Said Masood, Medical Superintendent and Vice Chairman, Organizing Committee, GMC Baramulla. Dr. Masood is not here. Thank you, ma'am. Thanks a lot. Ladies and gentlemen, we rarely get this kind of an opportunity to listen to the words of great personality. So, let us have the privilege of listening to the message of our chief guest, Professor A.T. Ahmed, who is Director of Seri Kashmir Institute of Medical Sciences and ex officio secretary to J&K government. Please, sir.
Honorable Principal, Madam, and Professor Altaf Shera, Professor Fazil Parekh, Dr. Akar, Dr. Afaq, distinguished faculty members, my contemporaries, friends, my classmates, especially among Dr. Trayusha, Dr. Rashid has just left most probably, but all other distinguished frontline leaders and Dr. Baldev Singh in particular, plus all other ones, Dr. Nisar Chaudhary. It's very difficult to name all of you because it will mean a lot of time. All the students in this class, including the teachers and students in this class, which I always love to be in the class. A very good afternoon to the organizing committee. My gratitude, not my attitude as such, for having invited me for this occasion, for a medical college which is in its infancy, and a professional life that all my contemporaries have gone through, and the ones who are in the pipeline today or in the classroom today. It's an honor to be in this classroom, rather than to feel that why are we here. I feel extremely delighted to be in this classroom because this is the classroom that makes us professionals that we stand before anybody later on. Our life starts right from the classroom, from our home, from our kitchens, with our mom, with our parents, with our fellow brothers, sisters, neighbors, and then the friends. And it is this classroom that transforms our lives. I feel immensely pleased to be in this classroom again, which is a distinctive feature that I also happen to be a student of Government Medical College, Baramulla today. I've had good learning today from the speakers who spoke earlier, that included one of my teachers, Dr. Altaf Sanshera. He has been my teacher, and there are a lot many who have been my friends, batchmates, and there are a lot many who have been the students here. I've seen a good number of students who are in the front lines, Dr. Mushtaq, and many others, all around, Dr. Wakar. Dr. Wakar in particular reminded me of my days of the open heart surgery that we would do and then wait for the heparin to go of its own rather than need for the programming because we didn't have. Many times we would be scared of light being off during winter months and the heart machine would stop and we would struggle. Believe me, at one point of time, I along with my perfusionist, Mr. Glamson, had to dissect the entire heart machine and its heat exchanger system for 2 days before we could operationalize it. And then we had to have the candle lights available to make sure that we could see the manual part of it so that we have to run it manually if the light would go off. Those were the days we've gone through. But then, if you see the Sherry Kashmir from Medical Sciences with its super specialties, where Dr. Baldev Singh has contributed a lot, and a great friend of mine, Professor Mahmood, was a big loss to the institution very recently, was joined this institution. The old stalwarts who worked in that institution have made that institution as it is today. 4 walls do not make any institution. 4 walls of this building will not make a medical college. It is you people. It is the builders of this institution, the teachers, the administrators, the engineers, the architects, everybody. And much more than that, it is the students, the scholars that will make it as an institution. And the raw material that you will have is the most important thing. That is the patient will be. I would urge the teachers to teach the students to make them clinicians of excellence rather than institutions of excellence. Because each clinician and each individual will be an institution in himself. The biggest test for any teacher, for any clinician, for any doctor is the patient that he or she is to consult every now and then. Second time, third time, as the visits go on, each and every day becomes worse examination for you. So the teaching has to be focused for the students who need to be not only the students of medicine, but the teachers of the world. So what we are creating is not the scholars, not the doctors, not the professionals, but the teachers of the world. Because the generations have passed on. And knowledge is something that is distinctive to the human race only on this planet. This is the characteristic thing, the most distinguished feature that the human race is, that we transmit this knowledge, and because of which transmission we continue to be human beings. This distinction does not happen with any other race on the planet. Somebody recited Holy Quran. Every word, every chapter every page, always insists in Holy Quran that I have given you the science of this, that, is for you to explore it, to research, to search. I would urge the college teachers and the administration, again, that while they are focusing, teaching of the students and preparing them as leaders tomorrow in the medicine, they should prepare them not only as teachers and the scholars, but the philosophers also. They should be putting forth the theories that would be relevant for next 100 years. Whether we agree with Charles Darwin or not, but sometimes you find it is certain moralist. There may be other theories of evolution. There may be theories of evolution. But then, when you study, when you go by statistical figures, you find certain phenomena which you cannot deny. Einstein said there are gravitational waves in the universe. Everybody defied it. But today we see it's true. He was not given Nobel Prize for theory of relativity. It was something else. But it was his constant effort to see and explore the universe. I don't want to go to the physics and Einstein and Newton's and all other things. But then I want to focus on the medical profession. The teachers should inculcate the habit of research in the students of the medical college right from the first years. That's what I stressed in the institution, which I'm leading today, for one reason, that by the time we are final year students or we are interns and we are pass-outs, we have no idea what research is. It's better that we start research from day one when we enter medical college. At least there should be 2 publications with the final year student before he leaves the undergraduate medical college. By then, he knows what the methodology is. By then, he knows what his future has been. By then, he knows what his ambitions have been. By then, he knows what the direction is going to be. And as long as you do at the initial levels, and you attach them to the distinguished teachers, the academicians, they will have a path laid down once more. We should not tread the paths that are already there. We should explore new things. We should lay new roads. We should be trendsetters rather than follow anybody else. It's very easy to join the crowd. It's very difficult to stand alone. It doesn't mean that if you are strong to stand alone, right, it's not important. No. It means that you have that much strength to be stand alone. And that is true of medicine, surgery, any interventional field. Medicine and surgery have ceased to be what they were some time back. Today's medicine is our interventional medicine. And the more of the interventional medicine, the more of the technological interventions that keep on coming because of knowledge explosion, because of the internet, because of the technological advances, the more we need to adapt ourselves. What was absolute yesterday will be obsolete tomorrow. So we must change our teaching patterns. The teaching should be more and more interactive rather than blackboard and other things. The more you have interactive teaching, the efficient students, the efficient teachers will be there. A teacher does not teach much to a student. In fact, he learns much from the students. And the teacher should be one who knows the weakest student at the back bench. The teacher should focus attention on that student. Because it is that student who needs guidance, help from a teacher. A genius does not need any teaching at all. If it can learn from a genius. And a teacher in whose class, if a student fails, my policy, my attitude is to punish the teacher. Because the failure of a student to me is failure of that teacher. And a class where students are 100% through means that's the excellence in the teacher. I have been always saying it, whichever institution I have led, be it Northeast, be it here, if I see any institution, be it undergraduate, postgraduate, that we have at the postdoctoral levels, all the nursing or the diploma courses. If I find any student failing in any of the sessions anywhere, I immediately call those teachers. I take them class, I give them my mind. I said, this time I accepted the exam now. I have certainly written harsh notes on their APRs, just because of this thing. I don't want to waste your time, but then the focus is, yes, being a medical college where you're producing the leaders in medicine tomorrow, they should be not only the clinicians, they should not be only the clinicians who have to do the private practice and treat. No, that should not be it. The day this medical institution also goes into private practice, it will mean end of this institution. I acknowledge it, I say it, I admit it. Our premier institution, Sheikh Medical is infested, not infected, infested with private practitioners. That is the beginning of the end of the institution. I've been saying it loud and clear, I'm not scared of anybody. Absolutely not. But the day, just realize, the day I feel the need I have less, I feel better. The more I feel the need that I need money, I need property, I need assets, I need this, I need that. What is the end? I need it. I have everything. I have space aircraft. I go to the Mars, I go to the moon, I go to stars. What then? The best would be creating human beings rather than machines earning the money. That would be another request to honorable principal and the teachers here, that they should produce students of medicine, the scholars, the teachers, the leaders of the world. The teachers in particular should focus not only on teaching, which is the classical part of it, but innovative and interactive teaching. And it should be with a bit of a more stress on what we say exploration, what we say the research. It should not be copy, cut and paste. It should be original research. It should be something good, something new. All those people working our stalwarts, they have some distinctive features. There have been generations of clinicians who have come and gone. They are not known even. There are few who are known by their names. And it is because of their contribution. The last I would say is, having done a good teaching, having produced good scholars, teachers and leaders of tomorrow, and good clinicians, good doctors and good human beings, then we should be able to have those team leaders whom you group in such a way that they establish different institutions, even in private practice, even in private sector, and in other government institutions. After all, it becomes a factory where you produce such a manpower who become individual institutions more. And as they go to different institutions, in my days, we thought of one medical college in Kashmir and another medical college in Jammu. But today you find a chain of medical institutions coming up. And tomorrow we never know how many other such institutions will be need-based. And you need to have the leaders available and create them from these factories, from these institutions, from these mother institutions. We are, most of us, from the mother institution, which is Government Medical College. And Institute of Medical Sciences today has most of the faculty from Government Medical College. The new generation is on, who are going to replace us. The last thing I would say to the Honorable Principal, Madam, and to the administrators, the medical student also, that when you are creating a new structure like medical college, where the restriction is on this and that, you will have a lot of difficulties on the availability of the finances, the funds, and then dramabazi of the contractors, the engineers, and so on and so forth. Please do not listen to them. Dictate to them. That is how I have done. I had an institution of 20 years languishing project in Maternity Hospital in Trust. All of you know it. When I joined in 2016, I said I would get it done. Half of it. I did it and got it commissioned in 2018 itself. The rest of the project was still incomplete. I joined again for my hat-trick part of the directorship. I completed it, got it signed in a commission this year. State Cancer Insurance Professor Makbul had done a tremendous amount of work, the best concepts, was at the basement level and we're just digging the basement. Is that right, sir? 2016? A number of meetings at that time. In that year only, I had raised it to the 5th floor. The top ceiling was there. But then I had to take Banvas, I returned, and then I completed it. State Cancer Institution is commissioned, so is Matter, so are many other engineering projects. I, in that 1 year of 2016, completed almost 13 projects, very prestigious projects. This time, without anybody knowing it, I have completed 8 more projects, all established, fine, done. I have expanded Shri Krishna Institute of Medical Sciences in 2016, that was 650 bedded. Officially. Today this institution, in the 2 states of 1.5 years each, today our bed strength is 250, 1250, officially. It is covered than what it was. We have not made any drama about it. We have not said or written in the press and no, silently done the job. It's only the official figure 1250 today. But then there are about 95 beds in emergency which are on trolleys literally. Though we have put beds there, but they're no trolleys. They're not counted in the statistical figures. The point I want to convey to Honorable Ma'am Principal here is that you will have difficulties, but don't listen to them. Take care of them. And give them deadlines. Fix their targets. Call them for the meetings and have a regular review meetings. Constitute an advisory committee the way I have acted. I take most of the difficult decisions in the advisory committee. Call them. I have the reviews. My Honorable Chief of Material Management, Dr. Fazal, is there. We debate, thrash each other and heads there. But it is that advisory committee that gives the solutions. It will make your life easy and it will have a smooth, you have no controversy whatsoever. And you will be fixing targets, achieving them in the development. My dear fellow students, scholars, friends, contemporaries, and one teacher also, I would be very happy to be with you time and again, but that is not to be. I'm going to be off the scene in the next 2 months, maybe next 2 minutes, you never know, because this is the position. This is J and K. Miracles happen only in Kashmir, nowhere else. God takes care of this region only, the rest of the world works off their own merits and credits. God is taking care of this piece of land and the inhabitants here and everybody else. So with these few words, all I need to say is, for everybody here, including me, that you have an opportunity, you have an institution which is coming up, and this institution gives you an ocean of knowledge, an ocean of opportunities, is for you to look at the shore and see the waves, the storms, the tides and whatnot, or venture into it, wet your feet, or catch some fish. If you're daring, and if you're dreaming, if you're adventurous, dive into it, get pearls on it. God bless you all.
Institutions are not made by the four walls of a building, but they are made by the ideas of scholars and students. And these ideas become part of our life when we leave the institute. Thank you, sir, for such uncharging words. Now I call Dr. Afaq Yusuf Shehbani, Organizing Secretary, for expressing a vote of thanks. Esteemed dignitaries on the dais, senior faculty, distinguished guests, and my dear colleagues, Assalamu alaikum, and a very good afternoon to all of you. I deem it my privilege to propose vote of thanks on behalf of the organizing committee. First and foremost, I would like to thank
the chief guest of today's event, Professor A.J. Anger, Director of Skills, who despite his tight schedule, found time to grace this event at GMC Baramulla. Sir, your presence today at GMC Baramulla is a big encouragement for all of us. I express my sincere thanks to Principal GMC Baramulla, Professor Ruby Rishi, without whose patronage this event would not have been possible. Thank you, ma'am, for your support and guidance at every step. I am highly thankful to Chairman JAKASI, Professor Fazul Kupare, and other senior members of JAKASI for connecting this event with the association. I am sure this tie-up is going to make the event special and memorable. My gratitude to senior faculty from other medical colleges, the speakers of scientific sessions from GMC Srinagar, GMC Anantnag, JBC, JLNM, district and sub-district hospitals of North Kashmir, who have traveled long distance to grace this event by their august presence. We have a delegate from ESCOMs who traveled all the way from Jammu to attend this CME. Thank you, Dr. Harvinder. I extend my thanks to amidst GMC Baramulla, Dr. Sayyid Masood, the medical education unit, and the faculty from other specialties for their unconditional support in organizing this event. This speech would be incomplete without mentioning the name of Professor Altaf Hussain Shera, the organizing chairman and head of department, for their support and able guidance in organizing this event. Last but not the least, my special thanks to Dr. Hakeem Wakar, the organizing secretary, Dr. Mahmood, other faculty members, consultants, senior residents, junior residents of the Department of General Surgery, the office staff, the audiovisual team, the caterers, the other staff, Johnson & Johnson, especially Mr. Nasir, and all those who are directly or indirectly involved in organizing this event. Thank you all once again.